Good morning, everyone, or good evening, depending on where you're located. I'm here in Texas. It's noon. It's noon, so I'm going to today's speaker, or the person I'm going to be speaking with, is Liliana Silva, out of Portugal, and let me invite her to join us right quick.
Hi, how are you?
Liliana,
Good
hey,
evening.
good evening. How are you? Good. Hey, thanks for spending some time of your evening with us. I really appreciate it. So I got to finally meet you in person for the first time at the Invista Summit in Vegas in February. Before that, there was lots of direct
Yeah.
messaging and emailing back and forth. So I really appreciate you agreeing to join with us today and just learn a little bit more about how you practice and some of the philosophies and things like that. And so for the crowd for the group that's joining, I see people are joining pretty quickly. If you have any questions, you can add them in on my screen. It's the bottom right corner. There's a little question speech bubble that you can do, or you can put it in the comments, and we'll try to get your questions asked that way as well. And then while we wait on the audience to come with some questions, we'll jump into some that I have. So maybe could you just tell the audience a little bit about your background just
Okay.
to start with?
I'm from Portugal. I'm an oral surgeon for about 21 years. And I started my practice in north of Portugal, Porto. Then I was also in the university in the oral surgery department, and then I did some formation in the Santiago de Compostela in Spain in implantology. And then in 2016, I started in the field of bone regeneration. I went to Hungary to Professor Istvan Urban, and I started in the field that I really, really am passionate about, and that's it.
Yeah. So I think you're also
Yes,
working on your or finishing up your
I'm
PhD right
finished
now.
my PhD in
How's that going?
precisely this topic, bone augmentation. I'm comparing some PTFE titanium reinforced membranes in the vertical augmentation, and now I'm at the end of the thesis, so I have to publish articles and write the PhD.
Yeah. Yeah. You have a lot going on. So let me just jump into the clinical side of things. So you talked about vertical ridge augmentation. That was part of your PhD. I know that I've seen some of your cases on your Instagram account. You get very impressive results. What is your treatment protocol for ridge augmentation? Like, I know that you trained under Dr. Urban, as well as probably some others. Are you doing are you doing like the collagen sausage for horizontal, and then doing PTFE with, if it's vertical? Are you using any of the perforated membranes, or are you using all the solid? And then
So we
what
have
biomaterials are you using?
we can in healed sites we can have different scenarios. So the first scenario is when we have bone deficiency in a healed site, and we can place simultaneously an implant, and we produce a defect like a dehiscence that can be an easy distance or a moderate distance when it's from 5 to 7 millimeters in the buccal wall. In those cases, I perform the sandwich bone augmentation, that is the layering graft. So we place autogenous bone chips with PRGF on the surface of the implant, on the threads that are exposed. Then we protect that layer with xenograft and anorganic bovine bone mineral. And on the top of that anorganic bovine bone mineral, we just place a native collagen membrane. But we need to stabilize that membrane because it's really important to don't get any kind of movement. So we have to immobilize with vertical matrix sutures, with resorbable sutures like Blackalon, or we just pin it. but it's really important to stabilize that membrane. And sometimes in those cases, we also perform a CTG on the top of the sandwich bone augmentation, and we just stage and we closed everything. Then we have the other scenario that is not possible to perform the implant placement simultaneously. So the body of the implant is completely outside the genetic bony housing of the patient, and we really have to stage. If we have a horizontal deficiency, we are going to perform a sausage technique that is very less invasive for the patient, very predictable, and we really can regenerate horizontally the ridge. If we have a vertical deficiency and an horizontal deficiency, we really need to use a form stable membrane. That's when we recur to the PTFE membranes, titanium reinforced membranes, because we really need to have form stable membrane to achieve vertical augmentation. And that's it.
Okay, how long do you wait to go back in and place your implant if you do if you don't do immediate?
When we have horizontal deficiency, we wait 6 months. But when we have a vertical one and we use, for example, a dense PTFE non-perforated membrane, we have to wait 9 months. If we use a perforated membrane, we have to wait less, because she rapidly transvascularized because of the holes. So generally we wait 7 months, 8 months. But we really have to wait more. So because biologically is more demanding, so the graft has to mature and we have to wait.
Okay. Talk about fixation for a second. So are you using screws or are you using tacks? And how many are you using? And then also, how do you fixate the
I
lingual?
prefer mainly to use tacks. In the sausage technique, tacks. Sometimes when in the vertical, in the dense PTFE, I can also use screws. But generally, I can use the tacks all in lingual side. Of course, in the mandible, particularly in the anterior zone, sometimes it is very hard to fixate in the lingual part, and only in that case it's at least for me it's more useful to use screws, particularly in the anterior mandible lingual side. But generally I prefer to use the master pin from Meisinger. I really like that pin,
Okay.
and it's really strong and accurate. I really can trust that tag.
Are you're trusting? My understanding on the tack is it's its strength, that it doesn't bend in dense cortical bone, and that's what makes it superior to other types of tacks. Is
Yes,
that what
it's
you see? Is
really
there more to it?
it fixates very easily, and the head of the tag is bigger and is much easier to remove when in the reopening. Sometimes the screws are very hard to remove, or we just simply don't remove because the head is not big enough. The tags are very easy to place and to remove as well.
Gotcha. So you talked a little bit about your protocol for immediate versus delayed implant placement. Um, so is it just if the defect is outside of the bony housing that you're doing delayed? Are you trying to, or maybe a better question is, how often are you able to do immediate,
So
and
when
how
I
often do you have
talked
to do delayed?
before about simultaneous implant placement, I talked in healed sides. But I think you are asking in particularly in socket sides. Socket side
Yeah,
protocol
yeah,
is
yeah. The
different.
sockets is
In socket sides, we have to get some criteria. So I have to have a patient that is no smoker. The distraction must be atraumatic. I don't. We just simply don't it's really important to not have an acute infection in the alveolus. So in those cases, and of course, we need to have enough bone height and width to place the implant in the right 3D position, prosthetically correctly positioned. So after that, if I have all that conditions, I place my implant. And really important is the buccal wall must be integrated, and the buccal width. It's really important also, not less than 2 millimeters. If I have these criteria, I do immediate implant placement. I fill the gap with autogenous bone chips or anorganic bovine bone mineral with collagen. And then I just reinforce the soft tissue with a soft tissue punch, and I just seal the socket with a provisional, an immediate provisional, respecting the critical and subcritical, like Oscar Gonzalez described, and everything is sealed. And I wait 3 months, and then I remove the provisional. But sometimes we don't have all these criteria, and sometimes we have some dehiscences in the socket sides. And my protocol, when I have dehiscences that are easy or moderate dehiscences in the buccal wall in socket sides, I really like to recur another technique that is called immediate dental alveolar restoration from José Carlos Rosa from Brazil. It's a very predictable technique, and it consists of going to the tuberosity. So we probe the defect on the buccal wall with a periodontal probe. Then we select the right chisel to that defect, and we go to the tuberosity. That is a very good graft because it's really vascularized, and we remove the future buccal wall of the socket, and we just fixate in the alveolus in the buccal part. Then I go to the same place and I remove another sample of tuberosity. I particulate it, and I fill the gap between the implant and the future buccal wall. And then always the same, I seal the alveolus with the provisional that is perfectly designed, respecting the contours, and that's it. 3 months after, I remove the provisional, and if it's necessary, I do again a soft tissue punch, and everything is preserved. It's a very, really predictable technique. When I have an infection, an acute infection in the alveolus, I just don't perform any kind of graft. I just clean everything, and I just place a PRGF clot, and I just close, and I wait 2 months to start over. But when I have when I don't have any kind of infection and it's not possible to place the implant placement in the right position, I just perform socket preservation with anorganic bovine bone mineral with collagen, connective tissue, and just seal the socket and place in Maryland. That's my protocol.
Okay. Yeah, no, you're right. When I'm talking about delayed versus immediate, they're kind of both. There's ridge preservation, then there's also the ridge augmentation. On the ridge augmentation, I think about, for example, Dr. Urban, he believes it's not worth the additional risk of placing implants at the time of vertical ridge augmentation, he takes more of a step by step approach. But then I know Ramon Gomez Meta, also a friend, and I know that he's more apt to do immediate if he can get primary stability, and then uses almost the implants as almost like tenting poles that he places graft around.
I performed Urban's technique totally. I agree totally with him. In heel sites, if we don't have, if we have a severe dehiscency, so if the body of implant is completely outside, we have to do a miracle at the time. So we regenerate, we regenerate vertically, and then we place our implants. And during the implant placement, we do also a mini sausage to protect that graft. So I agree totally with that technique.
Okay. Got it. And then on ridge preservation, it sounds like if you can get primary
Yes.
stability and if
No,
there's
no, no,
not an
no.
infection,
In
then
in
generally you're
the
going
socket
immediate.
preservation, we cannot
Okay.
place the implant in the socket because it doesn't have primary stability. So in order to preserve the socket, and after 2 months do the implant placement, we do the socket preservation. So we have two
Oh, I
worlds.
see.
We have
I got
socket
you. So you're
sites and we
waiting
have
two
healed
months.
sites. In socket sites, we can, if we have no infection, if we have a very good buccal wall, or even some dehiscences that they are moderate or easy. But if we can place our implant with primary stability, we do implant placement, we fill the gap, and we just close with the provisional. That is a scenario, socket side. But when we have
Hmm.
ill sides, it's
Yeah, yeah.
different. We can place the implant
Right.
simultaneously, and we overcorrect the dehiscences, or we just cannot have the implant placement and we stage. That's it. In severe dehiscences.
Okay. Okay. Um, Maybe we can move on to another, hot topic,
Yeah.
which is periimplantitis. Treating periimplantitis, and then there's always this debate of, do you try to save the implant? Do you extract the implant? Do you go with, I think 90% of people ask the question. It's you hear two answers. One is depending on how much of the threads are exposed, but then you sometimes hear another answer that's really a matter of if you place the implant or if it was referred to you. So, what is your thought on treating periimplantitis? And if you are treating it, when do you decide to remove versus regenerate?
So I
And what's
changed
your
my
what's your protocol?
protocol in a recent past because recently I have a new
Okay.
tool that I can recur. That is the electrolytic cleaning of the implant. That's why it's a very recent past to me. So first, we have to be sure if the implant is prosthetically well positioned and what went wrong. It's really important to see what went wrong.
Hmm.
Then, if the implant is correctly positioned and if I have a component, interosseous component of that implant that I really can fight for him, I have mostly three paths. So it depends on the defect. Of course, if we have a very good maintenance program, we will identify periimplantitis very soon. So in those kind of defects that are diagnosed very soon, we will see vertical defects, but all the walls of the implants are preserved. In that cases, I just remove the prosthetics. I just let it heal the soft tissue for about 2 and 3 weeks. And then I just open a mini flap. I remove all the granulation tissue and I clean the implant with the Galvo Surge. It's a new tool that is really, really interesting because it really cleans the implant, because we really see in the reopenings of those defects, we really see regenerated bones. So I have sure that that implant is cleaned, because otherwise it would not be biological possible. So in those kind of defects that I have vertical defects, all the walls preserved, I just clean the implant. I just put bony chips autogenous in the gap. I just put again the prosthesis, and I just let it heal like a socket, an immediate implant placement socket that I already referred. But if we have vertical defects with dehiscences, and if we have buccal dehiscences, I prefer to perform close healing and a sandwich bone augmentation. So I do the same protocol. I remove the prosthetics. I let the soft tissue heal. Then I raise a mini flap. I just remove all the granulation tissue. I clean electrolytically the implant, and then I place bony chips autogenous in the surface of the implant, and then I protect with anorganic bovine bone mineral. I just stabilize everything with a collagen native membrane, and I stabilized with tacks or with vertical matrix suture, and I close everything, and I just reopened after 3 months, and I just then placed the prosthetics. But normally we also have to do some soft tissue management after that. But we have even another situation, that is when we have horizontal defects. So we don't have any kind of walls around the implant, and those, of course, are the more demanding cases. So there, I really have to use again a form stable membrane, a perforated one. Um, in this kind of defects, once again around the surface of the implant, autogenous particle chips, and then the mixture of autogenous particulated bone with xenograft, and everything is stabilized with tags and dense PTFE perforated membrane, the RPM.
When do you, are you trying to regenerate everything, or what if you, I mean, I think I don't hear very many clinicians saying that they're trying to save implants if there's more than 50% of the threads exposed. Not that it's not possible, but more just like there's this like 50%. I don't know if it's in the literature or where this comes from, but that's almost like that's the most common answer I get is, do you operate with the
No, each
same
case
idea
is
or
one
different?
case. It depends if we are in the posterior mandible, if we are in the static zone, because if we can regenerate a static zone of this demanding defect, we will have to improve the soft tissue, like recurring to the platform technique, to a sheep papilla. So each case is one case. So we have to study very well the case that we have in front. And once again, if the implant is prosthetically very well positioned, and if it's worth all the work, because otherwise it's easier to remove, to explant and start over again.
Yeah. Okay. Um, and the galvo surge. So that's it sounds like you
I
have some
don't
experience with
have
that. Have you done a lot of
yet
cases,
lot
or are
of
you just something you're starting
experience.
to
I
teach?
have at least 10 cases, but I only did like 3
Okay.
reopenings, and I can say that kind of tool, and I'm not selling nothing, it really cleans the implant, and that's a game changer. Absolutely. That's a game changer, because in the past I just explanted the implant, even if it's mine or the other. I just prefer it. For me, it was more predictable to start over again, to explant, and because I didn't have any tool that really cleans the implant. And today it's different. It's different.
Gotcha. And how much regeneration are you getting? So it sounds like you weren't doing a lot of periimplantitis regeneration before. Now you are. Are you getting, I've heard that some people, like, if I can just get 2 more threads covered, then that'll increase my success rate of the implant. Or I've also seen cases where people get complete regeneration all the way up to the top of the implant. Like, what's your expectation when you regenerate a
So
periimplantitis case?
when we perform, it depends of the defect. Of course, we have defects. Once again, if we have vertical defects with decencies, are more easy to regenerate completely than horizontal deficiencies, when we have no walls at all, and when we have only intraosseous component, and we don't have any walls at all. But it depends on the case. But when I decide to regenerate, I try to get all the all the conditions, the ideal conditions, so the biology have a chance to regenerate that defect. So I reopen very few cases yet, so I don't have a very big casuistic yet. But I can say to you that it's really possible, and I have already saw other colleague cases. This one already showed that as well. So it really can happen. The
Mhm.
total generation of those defects.
Okay.
It's possible.
Yeah. Awesome. So when you're regenerating in with perimplantitis, I hear that it's kind of similar to your ridge augmentation protocol, but you're using the perforated membrane. I think on the regular vertical ridge augmentation, you're still using
Yes.
maybe more of the traditional the titanium reinforced membrane. How do you decide when to
It
use one
depends
versus the
of
other?
especially of the difficulty of the defect. If I have a very demanding defect, I want that the transvascularization occurs faster, so I prefer the perforated membrane. So if I have a very extended defect with a very thin base, so biologically is really demanding, I prefer the perforated membrane. But of course, in the perforated membrane, I will have a more soft tissue infiltration, but for sure, I will have
Mm-hmm.
fast maturation of the bone. And I could see that also histologically because of my PhD, I can see trabecular bone is very, very, very good quality bone as well. But the dance PTFE also works, not in so demanding cases, but I think and in those cases of dance PTFE, it takes longer, of course, but I really don't see any kind of soft tissue infiltration. It's a really occlusive membrane that has advantages,
Yeah.
of course, but it has disadvantage as well because
Yeah.
it takes longer, but they
Yeah.
are both really predictable.
Gotcha. Um, just two more questions. I know we're time has flown by. Uh, Complications. Let's say you have an exposed membrane in your ridge augmentation procedure, whether it's with the perforated or the non-perforated dense PTFE. How are you treating those? Are you removing? Are you cutting the membrane out? Are you leaving it in place and watching it? How do we treat that complication of dehiscence? Because I know dehiscence is kind of like it's the most common complication that we see in both the literature and from our
So
our customers
we really
talking us
have
through it.
to practice very well the periosteoelastic technique, because if we practice a lot the periosteoelastic
Yeah.
technique, it's really rare to have exposure of the membrane. We really have to
Yeah.
respect all the anatomy and all the protocol. That's why it's sensitive, but it really works. But when we have adhesencies, we can have early membrane exposure. Um, just before just in 3 weeks, and it depends if we have an infection with that early membrane exposure, or if we don't have an infection. If we have an infection and if we see pus, we really have to prescribe antibiotics and we have to remove right away the membrane. If we don't have infection, the goal here is to maintain the membrane as much as we can. 6 weeks or until 8 weeks, it would be perfect. But we want to maintain the membrane as much as we can, and then we remove the membrane and we just then cover everything with a native collagen membrane, and we just wait until the 9 months is performing. But those kind of exposure mostly happen because of the flap management, because we over thin
Yeah.
the flap. That's why the periosteoelastic technique must be really respected. We have to do a very superficial incision in the periosteum, and then we just have to put the scalpel on the table and just work with periosteums, because otherwise we are going to overthin the flap, and that's why the dehiscences happen, especially anterior maxilla in the type 4 defects, when we have no vestibule and we have a stone-like periosteum, and we have to recur to a suborbicularis preparation. So in those cases, they are really demanding cases, and sometimes we really have overthinned the flap and the dehiscesis happened, or in the posterior mandible, in the lingual side of the flap, because we really have to respect the insertion of the myeloideo and all the three zones in order to not overthin the flap, and that's why things happen predictably. Great.
Yeah. Okay. Well, awesome answers. Hey, final question. So I know you do, like, I see you more and more on main podiums giving lectures. You did some lecturing at the Invista Summit. Like, I know you're doing more and more teaching. And then I also understand you also have your own teaching institute now. So if people want to see what opportunities there are to learn more about these different topics, where do they go? And also, are these courses at
Yes,
your, are
Portugal.
they in
They're in
Porto or
Portugal,
where?
and they are in north of Portugal, in a city called Aveiro. It's 30 kilometers from Oporto, and
Okay.
that's where I'm going to teach. I was pushed by some professors and some colleagues to share all the techniques I have the chance to learn from different mentors. And I'm really excited also to start with that part of my professional life. I also started to teach in my university again, in my department of oral surgery, and that's a really honor to do, because I really like to share and to have those kind of interactions as well. It's really nice.
Yeah, sure. So, is the teaching institute, is it adjacent to
Oh
your
no,
clinical
it's
practice, or
separate.
is it
It's in
separate?
another city. Yeah.
Okay, okay, gotcha. And where do we go to learn more about the courses and dates
Yes.
and things like that? Is there a website?
ldsregeneration.com. LS. Liliana
LDS?
Silva. LS.
Oh,
Regeneration.com.
lsregeneration.com. Awesome. Well, hey, I really appreciate your time this
Ready, Jane?
evening and sharing all the
Already? Done?
knowledge. Uh,
Really?
it's already thir 34 minutes after. Yeah, time flies with maybe we can do this
Great.
again and dig into some
It
other
was a really
topics.
honor to be here today, and I really like all your team, and all your enthusiasm about this topic that I really love too. So it was a very great pleasure to be here today. Thank you, Cheng, for the opportunity.
Oh, thank you so much. Have a great
Thank you, Cheng.
evening,
Bye
and
bye.
look forward to talking soon. Okay, bye.